brilliant. Okay, so hello everybody. Welcome to this SOM webinar on equality, diversity and inclusion. I'm Jenny Napier, I'm the chair of the SOM Future Leaders Group, and so Sheetal, Sade and Janet have kindly agreed to put something together to help us think about equality, diversity and inclusion and how that pertains in particular to leadership. Just to let everybody know, the meeting is being recorded. In terms of housekeeping, we've got 3 presentations to hear. And so actually, if we have questions, when you have questions, please put them in the chat box. And we're thinking that questions could be answered at the end just to make sure that we cover the ground and then actually have more time for discussion towards the end. But please do feed them into the chat box as we go. And I'll try to make sure that we actually get a chance at the end to answer them. This is a really important topic that actually relates to every single one of us. In some ways, we can see that there are some problems related to equality, diversity and inclusion, both in society at large, in our professional lives, and in particular, maybe at leadership representation levels. But what we know from the research in general is that there are benefits of having a more inclusive and diverse approach in organisations in general, for both performance and for people's well-being. And so really today's webinar, which has been put together with a lot of work behind the scenes, is actually to help us all think very personally about how this topic relates to all of us in our everyday lives. So I'd like firstly to welcome Dr Sheetal Chavda, who is a consultant occupational physician and working as the Deputy Regional Medical Director at Health Management Limited. She's also the Chief Medical Officer within that role for London Fire Brigade. As well as this, Sheetal is a SOM board member, a member of the Faculty of Occupational Medicine, and is the Chair of the EDI Taskforce within SOM. So thanks very much, Sheetal, and over to you.
Thank you, Jenny. Welcome everyone. Before I go into my presentation, I would like to just start with a poll, and I believe Nick has a poll ready for us to start with, which is to get us thinking about equality, diversity and inclusion, and what you think could have the most impact on equality, diversity and inclusion in an organisation. So there's 4 options, and of course they're all important, but I'm just looking for sort of something that you feel is going to have the most impact. So if you're able to just answer the poll, and if you feel that there's something else that's not in the option, then please do put that in the chat box and we can discuss that. And I will repeat the poll at the end of my presentation to see if there's been any difference in terms of the outcome of that. Give you a couple of minutes or a few seconds probably to finish that. So are we ready? Have we got the outcome, Nick? Right, okay, that's great, thank you. So I've got education and awareness with 47%, monitoring and accountability 29%, strategy and policy 24%, and right, that's it. Okay, so that's really interesting. Thank you everyone for doing that. And like I said, we'll pick that up again at the end and I can give you my thoughts on that. And we'll also be interesting to see if that changes after the presentation. So I'm just going to start sharing my screen. I believe people should be able to see that. I'm just going to go into presentation mode if I can. Oh gosh. Right. Can people see that? Mm-hmm. Perfect. So why is diverse leadership important in healthcare and occupational health? It's a huge topic, and it's very, very difficult for me to think about all of the different areas within diversity and inclusion and leadership all at the same time. So it helps me, at least, to break things down in different areas. So in my presentation, I'll be looking at equality, diversity and inclusion in healthcare and NHS. I'll also be looking at equality, diversity and inclusion and how that impacts on patients. And then, of course, we're in occupational health. So we've got our own issues with lack of diversity and discrimination. And then we deal with workers, and there is an issue there as well. But of course, they're all interconnected, they're all related to each other, because a lot of us will be working in the NHS. A lot of us are working outside of the NHS for various different organisations, which have varying practices when it comes to diversity. We also, day in, day out, speak to patients who are likely to be getting treatment from their GPs and the NHS. And then, of course, these patients are workers as well. So it's really helpful, like I said, to just break things down into different categories for me. But of course, like I said, they're all interrelated, connected to each other and influence each other. Sorry. So I just want to give you a little bit of information in terms of the status quo and in terms of the experiences of patients within healthcare, just to get you to start thinking about why diversity is important and why it's important to have EDI, certainly at a leadership level. So a lot of you will be aware of the Francis report, which was published in 2013. And that was an inquiry conducted by Mr. Francis into events at Mid Staffordshire NHS Hospital, because there were serious failings within that hospital, and there was very poor patient care at that hospital. And that report found that people with disabilities were struggling to access appropriate care and support, and therefore they had less favourable health outcomes. They also found that NHS employees who said that they were disabled were experiencing difficulties accessing the support that they needed. About 15% of them felt that the NHS didn't make adequate adjustments for them. And that's really shocking and surprising for me, because, you know, NHS is a healthcare organisation, and really these organisations should really be role modelling reasonable adjustments and supporting disabled employees, which certainly they weren't doing. And of course, in terms of discrimination based on gender, the report found that there was stigma around certain illnesses impacting the likelihood of women accessing services. They also found that within the NHS, general workforce is predominantly female, fewer men, but as you get higher, when you get to the senior leadership level, the proportion of females to males is a lot lower. And again, focusing on the experiences of patients, but now based on ethnic minority groups. So they found that some ethnic minority groups had higher levels of ill health, so diabetes in South Asians, and about 3 times increased risk of mental health in Afro-Caribbean groups. But they also found that there was increased dissatisfaction by those groups compared to the white population. And then other groups just experienced huge prejudice, rejection, discrimination, groups like gypsies, asylum seekers, refugees who already had very low levels of health and well-being. And the report found that the main barriers, the main issues were around communication and language difficulties, lack of recognition of ethnic differences, and of course, different ethnic groups are different. They're not a homogenous group, but there was very much a lack of understanding, lack of recognition, ignorance of problems facing communities, dismissal of a lot of the issues facing those minority groups, and a general lack of confidence in how to deal with issues arising from their backgrounds. If we talk about discrimination in workers within healthcare, and again, I'm going to focus more on the NHS because that's where a lot of the data is. There's evidence of gender discrimination that workers experience within healthcare, evidence of more casual sexism, lower pay, and interestingly, weaker recommendations for jobs when it comes to female employees compared to their male counterparts. There's also disability discrimination, like I mentioned. Disabled employees within healthcare are less likely to feel part of a supportive team. They're less likely to be supported by non-clinical management. Religious discrimination, evidence that Muslim doctors face more frequent and serious levels of discrimination, and discrimination based on sexual orientation. And then I think a lot of people will have heard of the Klein report. Roger Klein did a report, again, within NHS, within healthcare, the Snowy White Peaks, which was published in 2014, which reported that ethnic minority workers within the NHS had poor experiences by every measure that they looked at. They found that they were more likely to be in lower grades, that they were discriminated against when it came to recruitment, promotion, awards, bonuses, more likely to report bullying and harassment. And this is backed up recently by the BMA surveys as well that took place during the pandemic, where they showed that ethnic minority doctors also reported more bullying and harassment, are more likely to be made to work with inadequate PPE during the pandemic compared to their white colleagues. We're all aware that actually ethnic minority clinicians are more likely to be referred for disciplinary action and or to their regulators rather than being supported or given appropriate training if there are issues. And just looking at sectors outside of healthcare and just, general workforce, there's evidence that ethnic minority workers are more likely to be in service and frontline roles. And of course, we know that that brings what kind of risks that has brought in recent times. And they're also more likely to be in temporary and insecure work. And that brings with it lower pay, and generally they enjoy fewer rights compared to people who are in permanent and secure work. So what is the status of leadership in healthcare? Again, I'm talking about the NHS. I'll touch on occupational health in my next slide. So in terms of the NHS, the data, like I've said, disproportionately favors white applicants when it comes to recruitment. There's a huge gap between the composition of boards and national bodies within the NHS compared to the workforce, compared to patients, compared to the rest of the local population. Some of you might be aware of the Race Equality Action Plan. I believe that was introduced in 1998 following the Macpherson inquiry. And that inquiry wasn't just looking at healthcare, it was looking at other sectors and other areas like the police and public bodies, and showed evidence of institutional racism and discrimination across all sectors. And so the NHS decided to introduce the Race Equality Action Plan in 1998 or around that time. But unfortunately, evidence has shown, despite a decade of that being in place, it's led to little or no progress. So in 2015, NHS introduced the Workforce Race Equality Standard. And this is basically 9 indicators for each individual NHS trust to monitor and report on. And that's to do with lots of different areas like representation at board level, reports of bullying, harassment, different areas of discrimination where there is clearly an issue within the NHS. For a few years, I don't think it had much of an impact, but I read the last report, which was in 2020, and I can see that there's been improvement in some areas. So they have actually managed to improve the representation of ethnic minority workers at board level and at senior level. And they've also improved senior manager pay band for ethnic minority workers. But for other areas, there's been no improvement. So when you look at recruitment and you look at reports of bullying and harassment, it actually hasn't made an improvement. They haven't been able to report an improvement. So coming on to occupational health, I've said there's very little data. What I really mean by that is that there's no data. I certainly haven't been able to find anything. Talking to people, talking to organisations and other key stakeholders as part of the work that I do for the EDI group within Society of Occupational Medicine, I think it's clear that there's just variable practices. There's very little monitoring going on, very little accountability. So I suspect that the status within occupational health outside of the NHS is likely to be the same or probably even worse, because the NHS has those initiatives that they've put in place to try and bring about an improvement, and they've got clear monitoring and accountability. Of course, if you're occupational health within the NHS, you can have a look at your own trust, you can have a look at your people plan, you can have a look at the res within your own trust and see how your own trust is performing against those indicators. And because there's so little data, I think within occupational health, I think it's really important to try and gather data. So as part of the EDI Taskforce and with the University of Glasgow, people like Professor Ewan MacDonald and Drishka Lally, I am involved in trying to investigate the experiences and progression of OH clinicians. So we're not just talking about doctors, we're talking about all OH clinicians, including allied healthcare professionals working within occupational health, to see if there is a difference between their experiences and progression based on their protected characteristics. So very much a focus on EDI for that study. So if that hasn't convinced you, I think that it's important, diverse leadership is important, and it's been mentioned. I'll just talk about the reports that I've already mentioned. The Francis report, like I said, in 2013 stated that there is a clear correlation between discrimination of ethnic minorities in the workplace and patient experience. Roger Klein said in his report, there's robust evidence that a diverse workforce is linked to good patient care. And talking about organisations outside of healthcare, just general organisations, the McKinsey report last year said that there is a robust business case for diversity and organisational performance. And they found that the greater the representation, the higher the likelihood of outperformance. And the Harvard Business Review has also said that teams with inclusive leaders are likely to be high performing, make high quality decisions, and behave collaboratively. So I just want to talk a little bit about what an inclusive leader does and what that looks like. So just being visibly committed. I think it's very obvious, certainly to me, when someone is visibly committed to EDI. It's not just something that they say, it's something that they do, and they very much focus on it in all or most areas within their organization. So I think for me, it's very obvious when a leader is committed to improving equality, diversity, and inclusion within their organization. There is an authentic commitment to diversity. They challenge the status quo. They don't just say, well, this is how it is, and these are reasons why there is an issue. They go beyond that and they say, well, actually, there is an issue, and maybe they need to think differently or do something differently, or maybe they need to make a bit more of an effort to promote diversity. They also hold others accountable and make diversity and inclusion a priority. I find that inclusive leaders are very humble. They're more likely to acknowledge and admit when mistakes have been made. I think it's really important to acknowledge that there is an issue, because I think we still don't see that. I've come across organisations where there is very much a defensive position to say, well, actually, we don't have an issue, and we're doing everything we can to address it. But actually acknowledging that there might be issues within the organisation. Being aware of your own bias, I think it's really important to be able to acknowledge that we all have different biases, and just being aware of that and trying to address that on an individual basis. Being curious and being adaptable as well, and empowering others and paying attention to diversity of thinking. Not everyone is going to feel confident to be able to speak up or to be able to say things that they feel. So it's just about empowering people to speak up and reaching out to people if need be to get their views. Again, on a similar theme, just seeking feedback and being comfortable being challenged as well, and being comfortable seeking out different opinions. I talked about visibility and being vocal, and also checking the impact that that's having, that your leadership style is having on the organisation. Just to finish off, I just want to talk a little bit about allyship. I'm certainly not an expert in allyship, but I just want to speak about it from a personal point of view, because I feel that I personally have benefited from allyship throughout my career. I think people have, at different stages of my career, people have reached out to me to encourage me, to support me, people who've been in positions of power and influence, to try and support and advocate for me. And I certainly feel very appreciative, and I certainly feel like I've benefited from allyship. Sade will talk a little bit more about allyship in her presentation, but for me, allyship just means being aware of your own privilege, and I think we all have a certain level of privilege that we enjoy in our day-to-day life and in our working life, and how can we use that to listen to other people's point of view, to acknowledge, believe their experiences, to actually advocate and support others, and to role model positive behaviours. And that just means, speaking up and challenging policies, practices. I do have experience of organisations where it's quite common to hear demeaning remarks, comments made about other people. And I think it's just important not to contribute to that kind of culture, and to try and challenge that where possible. Just educating yourself, avoiding assumptions, questioning stereotypes, going beyond the obvious, and challenging things beyond the obvious, if that makes sense. And like I said, all of us have our own biases, and I certainly did. And I was very lucky to have some formal training when I was working at Transport for London on recruitment practices and managing people and equality, diversity and inclusion. That's where I really started to address and become aware of my own prejudices and conditioned way of thinking that I developed over time. So really just becoming aware of that. And I'll finish there. I've listed some of the resources and reading that people can do on RES and the NHS Workforce Disability Standards as well. So people can have a look at that if they're a bit more interested in some of the things that I've mentioned. Thank you for listening, and I'll finish off with the poll. If we can have that poll again, Nick, just to see if there's been any change.
Great. Whilst people are doing the poll then, Sheetal, I'll just say thank you very much. That was really interesting. Brilliant to hear of the various pieces of work that have been taking place and some of the recognition of the problems, but also some of the movement towards solutions. So that's a really helpful overview. And I shall look forward to seeing whether the poll results have changed now.
Me too. I think initially the top answer was education and awareness. So let's see if that actually is the same, or have people changed their minds? Okay, so great. I think that there has been a change. So we can see that monitoring and accountability is now the top answer. And actually, I would agree with that. So I think my presentation really was looking at monitoring and accountability and how that can lead to tangible changes. It's not an easy answer, and certainly, like I mentioned in my previous slides, the RES, it's making slow progress, but there is certainly some progress happening. I think that obviously education, awareness and strategy and policy are important as well. I think without monitoring and accountability, very unlikely that things will change. So thank you for that. That's great.
Thank you very much, Sheetal. That is wonderful. Now, I would just like to say we are at 12:30. So I'm just wanting to ask quickly with Sade and Janet, are you okay if we overrun?
Yep, we're fine.
Yeah, okay, thank you. I mean, I know that might not be the case for all participants, so let's see how we do. So I'd like now to introduce Sade Adenekan. Who is got a very impressive resume. She's Assistant UK Occupational Health Manager at ExxonMobil, and she's also a UK accredited specialist in public health, travel and occupational medicine with lots of experience in health services management. She currently oversees 2 teams within the oil and gas industry, is a member of the FOM, the American College of Occupational and Environmental Medicine and the Society, and she also sits on the Inclusion and Diversity Taskforce, as well as which she is the co-chair of ExxonMobil's Women's Interest Network, and as well has helped set up their Black and Ethnic Minority network, which is known as Embrace. That's a brilliant name for the group. So really over to you.
So thank you and good afternoon to everyone. I am going to put myself the video off, sorry, because my connection's a bit dodgy and I don't want it to just cut off halfway through, if you don't mind. So as Jenny has mentioned, my name is Sade Adenekan and I'm a consultant in occupational medicine. Needless to say, I'm not here today in the capacity of my current role working for Exxon, but as an advocate and promoter of EDI within the workplace. So, and just a quick plug as well, for those that do not know, we do have an EDI task force I know Sheetal mentioned it, and we're all members of that task force. So for any colleague today that are interested following this talk, please contact us after the meeting for further details. So Sheetal has given an overview of the equality, diversity and inclusion context and some of the challenges faced by us professionals using the inclusive leadership model as a way forward to help inform allyship within healthcare. I, on the other hand, will be looking at how, through an allyship role, we as OH professionals can help to promote EDI within the workplace from a more practical day-to-day perspective in our current roles. So my talk won't take long. Hopefully it will be done within 15 minutes, so we don't tend to overrun too much. And I'll be happy to address any questions as part of the panel following our talks. For me, there will also be 2 poll questions, just to reassure you that they're totally anonymized. And we'll just go into what we're talking about today. So as you know, today's topic is pertinence. You know that over the last 16 months or so, with the emergence of the COVID pandemic, it has come with a number of EDI related issues. And no, Sheetal mentioned a few in terms of the disproportionate impact on Black and ethnic minorities and Asians as well as those with mental health and other physical disabilities across all sectors and not just the NHS. Needless to say, EDI is not just about providing adjustments for employees with disabilities, as I will hopefully demonstrate through the case examples that I will be talking about later. So as an overview, today will basically be in 3 sections: a brief look at the definitions of equality, diversity and inclusion. It's a bit of a mouthful, so I'll be referring to it as EDI going forward, and give an overview of allyship as well, and how we as professionals can promote EDI through effective allyship within the workplace. And I'll give 3 examples of cases that I've managed personally. I will end the talk with some guiding leadership principles that we as practitioners can use to inform our roles as EDI game changers. And there will be some 3 key messages hopefully you will also find useful. So I want to start with a quick EDI moment icebreaker. So what do you see? Some of you will see a young lady with her side profile, and some will see an old lady with her chin resting on her chest, and some will see both. And I put this up because we all see and hear things, but we process information differently. And today's no exception. So there has been a lot of information and more to come around EDI, but we must acknowledge the importance of what we take away from today and how we use it to address our individual practices. So the message is there are no right or wrong answers, and hopefully we'll be able to learn and reflect on what is said, as you never know, we might just make a timely difference to someone in their OH leadership journey, as well as help to improve and promote EDI within the workplace. So we're going to start off with our first poll to gauge the temperature check of where we think we're at. Nick, if you can pull up the poll question. So do you think EDI is important in your role as an OH professional? So that's just a quick, give you a few seconds to give us a baseline and see where we're at. We'll give that a few seconds and then we can pull up. Nick, if you can pull up the results for us. Ah, it's nice to know. So I'm talking to a converted bunch here, so that's brilliant. So thank you. That also helps. So that helps us move on quickly to the basics of the definitions. So I just thought I would start with the basics. So for me, equality is about, everyone having that equal chance, regardless of their backgrounds, affinities. Diversity is everything that makes you unique. And inclusion is about creating that, the act of creating fairness. So why do I ask this question as to whether or not we have a role in embedding or promoting EDI in general? So when I first started in occupational health, there was the perception of I was only there to provide advice, recommendation, guidance, and not get involved, or seemingly not get involved in any management or employee disputes. And to also remain as impartial as I could whilst doing so. So when things didn't necessarily go the way I expected, I found myself trying as much as possible to avoid getting a formal complaint that will ruin my ARCP as a trainee or my annual appraisal when I became a consultant. You might find that funny, but I think many of us as practitioners will also see that as a case and could, relate to that. So then, what are we about in our current role? So while reflecting and preparing for this talk, I asked myself the question, do you see yourself as an EDI champion? And without realizing it and reflecting to my years as a trainee and over the last few years as working as a consultant, I actually saw a lot of EDI related cases and felt that I did play a role in promoting EDI within the workplace. And then you wonder, well, how is that possible? Well, I think Sheetal has hit the nail on the head earlier by talking about allyship and the importance of it. And for those that don't know, it's not a fancy concept. And I know people have badged allyship historically around the context of employee welfare, employee well-being, or working with affinity groups, also known as employee resource groups. So those looking at gender, race, mental health, and the like. But in general, it is an evidence-based concept. And if you don't remember anything from today, just remember these three things about allyship. It is intentional. It is a positive concept. And it also takes a conscious effort in order for people to make that difference when it comes to promoting EDI. Most importantly, it is a journey. Okay. There are no fixed answers and no one size fits all. And even the same situation can be presented but addressed differently. And so where do we come in? Well, as you can see, allyship has a huge spectrum, and it ranges from being apathetic from one end, where you have no understanding of the issues at all, to increased awareness, becoming more active, and ultimately becoming an advocate. As OH professionals, we have a choice. Yeah, we can stay at the apathetic end of the spectrum with little or no awareness of organizational EDI issues and position ourselves as far away as possible from the essence of what equality, diversity, or inclusion might mean in the workplace. And be perceived as a service that believes in silo working with poor strategic engagement and minimal impact, and therefore obtain a reputation of being a service of poor value. Or we as professionals can become more aware of the situation within organizations and take on a more active and advocacy role in order to make that difference for the better. So what do I mean in practice? Well, I will illustrate by using three cases that I've come across. I obviously have changed the names and situations, but these three cases came within my clinical setting as referrals for managed stress within the workplace. And, that's a very common a referral that most of us get. So Peter was a 32-year-old logistics manager, and he was referred with anxiety as he had been off work with stress for about 10 months. And they had then decided to take him through a disciplinary, which in hindsight was a bit late. When the referral came, they had just written on the management referral that's stress at work. So I asked for further clarifications in the referral. And then they mentioned that he was a very poor team player, did not engage when spoken to, and he had a history of anxiety. So I saw him, we had a very frank discussion as to, you know, what was going on with the workplace and what had led to him going off. And he had mentioned that, you know, he had joined a new team, they had a new manager, she was much older looking. So he had seen her as, in terms of being respectful towards her. When he had an audience or spoke to her, he never looked her in the face. They also had a culture of going to the pub after work, which was their main way of socializing and team building. And he was a Muslim, so he did not drink alcohol. So in terms of looking at some of those factors, the report went back to them, highlighted that there were some specific work-related concerns that would need to be addressed. The manager, thankfully, called me up and we had a long chat. And she had highlighted that it was a HR disciplinary process. She didn't feel it warranted that. We then spoke around some of the culture awareness, and we ended up, I ended up running a training session for some of the HR and managers around culture awareness. And so for our second case, John, he was a project manager who was referred for stress, again, within the workplace, and because he kept on falling asleep in meetings. And after being embarrassed publicly in a meeting, he went off with stress. He came to the clinic, informed me that he was a new dad of twins, 10-week-old twins, and he had been juggling work with supporting his partner, and he basically wasn't getting enough sleep and turning up at work. He wasn't aware that there was a work-life balance policy, and his manager wasn't either. So it was just a matter of signposting them to HR and putting into place or actioning in the policy so that he had a more flexible way of working in order for him to get the work done and get some sleep as well, and not get signed off work. So he was able to return to work. So our last case was Sally, a 53-year-old office manager. She'd been in her role for about 28 years. And she was referred, again, stress at work, because she had started to forget things and was reprimanded for forgetting to lock a safe within the office because she had misplaced her keys. And she later found out that the keys were actually in her handbag. So she went off with stress and was actually thinking of retiring after 28 years of service. So while having a chat with her, although she did have a history of anxiety and panic on occasion, she mentioned that in the last 6 months, she had been struggling with the menopause and found it difficult to talk to anyone about it within the workplace because she worked in a predominant team of male colleagues. And again, we had that chat. She was able to disclose the situation to her line manager, who was totally appreciative of that because he also had a wife going through the same thing. And with the help of the FOM menopause guidance, we were able to put in some adjustments for her. And I also liaised with their HR and they were able to put in place a menopause policy and guidance as well. So as you can see, all three cases did highlight a number of EDI related factors that did present within OH. Although they all came in as the same referral as stress in the workplace, and we all know that it's quite common for us as OH professionals because at the time, you know, stress at work made up about what, 75 to 80% of my caseload within the clinics, and you can see that we were through OH we were able to make a difference in each of them, even though they all presented with different situations. You know, for Pete, it was more about understanding his culture and his religion and taking that into context when we provided advice. For John, it was the context of him managing his work-life balance better. And for Sally, it was the context of her age and accompanying physiological changes that all needed to be made aware of. And they all presented and were clearly managed differently on these simple leadership guiding principles of raising awareness and education, as in the case of Peter, as well as Sally, who meant that we had to put in a particular policy and guidance to help support her. And so looking back, these were all cases I managed as a trainee, so it's not something that you have to be a leader within OH to make a difference. But I'm finding that as I've evolved more into a strategic role, I'm now getting more involved with strategic development, working with employee resource groups, as well as law and HR. And so the lesson here is that leadership does come at any role, at any level within our roles as OH professionals, whether you're a technician or a nurse or a physician, and not just directors and chief medical officers. So I think we all have a place to play. So in reflection, I think as OH professionals, we are uniquely placed to make a difference. Allyship has been shown to work, even if it's just by simply promoting awareness, improving engagement, or just being curious as to why things are going wrong and why people are sitting in front of you, and how you can make them more inclusive and promote more fairness within the workplace. After all, Maya did say that we all do the best you can until you know better. And when we do know better, we should do better as well. So my three key messages are that occupational health can have an important role in promoting and embedding EDI within the workplace to ensure a culture of fairness. I think allyship is about being intentional as well as positive and making that conscious effort. And I think as professionals, we can all make a difference by promoting awareness, improving engagement, or just being curious. So I hope you found today's talk insightful. And again, I'm going to end with another poll as to see how you, as a practitioner, see yourself promoting EDI following this talk and reflecting on the cases that I've discussed as well, because I think all of us have come across such cases and have dealt with such cases accordingly as well. So just give you a few seconds.
So Sade, thank you. I'm just going to say thank you very much whilst we're waiting for the poll to come in. That was a really lovely talk, and I particularly enjoyed the fact that you illustrated some practical ways of resolving some of the issues with those cases. So thank you. Very interesting indeed. And it's really good to hear about the concept of allyship as well. And I think embedded in your talk is this idea that all of us we can all move along this continuum of awareness and more engagement on some of these topics as we evolve. So thank you.
Thank you. And it's nice to see that everyone wants to play a role and sees themselves in taking a role in promoting EDI going forward. So thank you.
Wonderful, thank you very much. So we have got our third and final speaker today. So I'd like to welcome Janet O'Neill. Hi, Janet. Janet is a clinical nurse director at PAM Group, and she leads the PAM Academy, which is their clinical governance and training branch. She's been an occupational health nurse for 18 years, so lots of experience, trained in South Africa, worked in Swaziland, so very interesting previous occupational health experience there. And she's been involved in management roles for about 10 years and enjoys mentoring. So it'd be very interesting to hear your contribution. Over to you, Janet.
Thank you very much. I'll just share my screen. Hopefully you can all see that. Oh, I think I've shared the wrong one, so I'll just go back and stop share and share again, if that's okay with everybody. And here we go. Okay. So hello, everyone. I'd like to start off by saying that actually I'm not an expert on EDI, as I'm still developing my understanding and awareness. But I hope that by sharing some of my experience and learning that I've had along the way, that people will feel empowered to start or continue their own development and assist with change. Because EDI covers so many areas, there is the potential that everyone has perceptions, regardless of their background. And I believe the only way to lead in diversity and inclusion is by looking within. This is actually quite a scary proposition, and it certainly was for me. Who wants to believe that they may have flaws, especially if those flaws could hurt or disadvantage others? So first of all, I'd just like to thank Sylvia Duckworth, who I got most of my graphics from today, because they're really excellent. But as Jenny said, I am a white South African by background, and I realize that people might have seen me in a certain light because of this. However, I firmly believed that I was not racist. My parents were very liberal and always instilled fairness in us. But as you can imagine, growing up in apartheid times, overt racism was all around me. Benches, buses, beaches, and of course, fear. I also, as Jenny said, worked in Swaziland, and I was the only white nurse in a clinic. And I was treated with utmost kindness and respect as a minority and very junior nurse before I came to England. Possibly because of my experience in both countries, I didn't see any racism in the UK when I came here, and I never really gave it a thought until COVID times and the George Floyd murder. Even then, it didn't really sink in. I was bemused by it. But then a mixed race colleague told me of an incident that she had experienced within occupational health where her ethnicity hadn't been recognized during a COVID risk assessment. And that really made me think. I began to realize that racism didn't have to be overt, but it could be subtle, and sometimes due to ignorance, although no less hurtful or concerning. And this realization about my own ignorance was the trigger for a learning pathway, which included a deep look first at myself. And as this graphic shows, the learning curve was steep and filled with emotion. I watched webinars, listened to podcasts, did e-learning courses, wrote articles, and joined the EDI Taskforce. What I would like to ask everybody, if they wouldn't mind just popping into the chat box any particular tools or any particular webinars or learning points that they have found have been really useful to them, because I think others will also find that really useful. However, I did feel that even though I had all of those learnings, it wasn't enough, and I felt that I really needed to speak to people. And that was quite scary, as I was worried about saying the right thing or saying the wrong thing per se, but it was such a worthwhile exercise, and I'm just so grateful to those that took the time to speak to me and give me an understanding of their experiences. And just to share an example of my original beliefs, my belief was that everybody needed to be treated the same, but as Sade's demonstrated so clearly, we do have to take culture into account. Otherwise, we aren't actually treating people as individuals, and we're not actually treating people with fairness. If we ignore cultural differences, then we ignore the biopsychosocial model that's so much a part and a parcel of an occupational health assessment. I realize that perceived racism can affect an individual's confidence in going into a leadership role. And therefore, that allyship that Sade and Sheetal mentioned is so important. Just going to swap slides. So when faced with a difficult question like inclusion and diversity, it is common for people to put it in the too difficult box or to want to put it in the too difficult box. And sometimes as a pressure to address EDI grows, perhaps because people see that things are going wrong, it might be, people might feel it's easy to take an off-the-shelf approach. However, it's unlikely that's going to be truly effective. And as leaders in occupational health, we have a wider opportunity within not only our own workplace, but in others, as Sade demonstrated. What we've got to look at is that all change starts with ourselves. Reflection is so important if leadership is to be successful, not only of our own biases, and of course everybody has these, but how we're viewed by others. It's not only about how we treat people, but how they see us, and we need to prove our intentions by demonstrating true inclusivity. What we've got to look at, instead of taking that off-the-shelf approach, is a more fluid approach, and that can provide us with significant dividends, especially with that reflection. And as mentioned before, it's really important to understand privilege, and that's certainly something that I had to grapple with in the beginning. Privilege leads to confidence, and confidence has a big impact on individuals' health and well-being as well as opportunities. By recognizing where there has not been privilege in others and how much harder they've had to work in life, or the disadvantages they may have experienced, then we can empathize and give that hand up that might be needed, that allyship. That bespoke approach to EDI does mean speaking and asking people about their experiences. It is scary, but people appreciate being asked, and it makes such a difference to our understanding and the change that is created from that. As an example, I recently had someone change the font in one of my documents, and clinical governance being my role, I do thousands of documents, where it feels like thousands. So to get someone changing the font in a document, you could take that quite personally. But I went to the person and said, why did you change that font? And they said, oh, it's because I'm dyslexic and I can't read that font. And you can imagine how awful I felt that all of these documents I'd written without a thought of someone who may be dyslexic and isn't able to see that properly. And of course, my goal is to make sure that all the documents are changed going forward to make sure that they're inclusive for everybody. Another topic where change is still required, as we've mentioned, is gender health issues, as many people are still uncomfortable about talking about this in the workplace, and good leadership can help to move this to a position of psychological safety. So when researching leadership skills that I felt that I needed to support change, I found some research that indicated that transformational leaders are more likely to have better outcomes with EDI. And I understand this type of leader enables the most effective outcomes because they are charismatic, they inspire teams, they take time to emotionally engage team members, act as role models, provide a clear vision, and ensure that every team member is valued. Well, I wasn't sure whether I was that kind of leader, so I thought I'll look deeper into what those skills would include, as I believe we all have the ability to learn and grow, and it's a constant process. So the first thing I looked at, and these are just the elements that I came across, is critical thinking, that active learning and reflection, that independent thinking, questioning assumptions instead of accepting them. And that, of course, is very much part of EDI. Occupational health practitioners need these analytical skills when undertaking assessments, and therefore it's a concept that we're already familiar with. And using that to direct learning makes sense, as it allows occupational health leaders to approach problems in a consistent and a systematic way. And a good place to start is actually by doing a self-assessment of where an organization is in relation to their EDI. We also need a lot of self-management and leading by example. And of course, that includes emotional intelligence, because recognizing our own emotions enables us to recognize and influence the emotions of the others around us. By being authentic, we can encourage those to be authentic and therefore have a greater psychological safety in work. And that's so important with diversity. Another helpful skill that I found was social intelligence, as that enables us to learn from successes and failures and not be afraid to change if outcomes are not as effective as we wish. In all likelihood, change will be constant as we continue to learn more. We need to be agile and flexible in our approach and constantly monitor progress. Leading change is a structured process, and a set of tools is needed, such as that in change management. People respond more effectively if they're part of the decision-making group, or they feel they've contributed, and that's where our communication skills are so essential. And having those working or focus groups is a great way to gain insight and buy-in. Providing education is another support with different diversity elements that can, and that could include workshops, webinars, and e-learning, as we've discussed. Leadership includes decision-making, as individuals need clear guidance, and without decision-making, that's not possible. And we need to share the vision, which is not only the why, but also the how and the when. People need to know what the goal is, what the expected outcome or benefits are, and how we're looking to get there, even if it is that is fluid. So, occupational health have a bigger responsibility to diversity and inclusion than other health professionals, in my opinion. I'm just caveating that, as we are often delivering that advice on disability adjustments and support. We have a wider remit, as we need to understand the impact of health inequalities on the individuals that we interact with. We need to come from a position of strength, and we can only do this if we look internally first. We have a responsibility to allyship and mentorship for those who may lack privilege within our own workforce, so as to allow them to thrive, prosper, and add value to both ourselves and our clients. We have a responsibility to educate, not aggressively, but persuasively. Now more than ever, occupational health is in a position of strength, reaching a far wider population than before. And I certainly firmly believe that that's growing. And we need to ensure that that reach includes an understanding of health inequalities and the benefits of inclusivity, which includes attracting talent, retaining staff, greater cultural understanding and empathy, diverse thought leadership and idea generation, which of course leads to improved services and development of services, and overall a thriving profession. So in conclusion, explore your own self, go out and speak to others, get curious, have courage, look at what leadership qualities can support change, understand the benefits, and make it count. And that's it from me.
Thank you very much, Janet. That was really interesting to hear your perspective, and in particular what stood out for me was your Swaziland experience of being treated with kindness and respect in that context, which could have been quite terrifying potentially if that weren't the case. So great. Really lovely to see the slides as well. So, and brilliant to hear of your own sort of really personal reflections, your proactive curiosity and seeking out. So thank you very much indeed. Now we have got time to, if people can stay, basically to think a bit about some of the questions. And we actually had a really interesting question from Nasrat that I can see Sheetal has actually addressed back in the chat box, but I'll read it out in case any of the other speakers have anything else that they'd like to say. So, don't you think that an EDI task force should become an organisation where doctors or any employee can turn up to in order to report their EDI concerns so they can be advocated and represented by this organisation? I think in this way, the EDI issues can be properly addressed rather than by encouraging individuals to speak up, right, and become alienated as a result. Okay, I'll just read out for everyone's benefit Sheetal's answer. Thank you, Sheetal. Sheetal agrees that addressing EDI issues on an individual level is important, but my view is that that's where things break down. Certainly an interesting concept to have an EDI task force to advocate and represent, but I'm not sure if SOM would see that as within their remit. I would like to know more about your thoughts. Are you interested in joining? Has anybody got anything else to say about that suggestion about EDI at group level, whether SOM or other organisations?
Jenny, I just want to add, just on that I very much see unions, and certainly for doctors, the BMA, being able to take on that role because they're very much experienced in advocating and representing. That's not to say that we can't do anything. And we have been actually engaging as a part of the task force We've been engaging with the BMA because I do think that Nasra is right, that where things break down, where there are issues on an individual level, that organisations have all these wonderful policies and strategies and all the work that they're doing, but on an individual level, things tend to break down. So I do think that there is an issue there. How that's addressed and who can take on that advocacy role is up for debate. And I think I certainly would very much like to know a little bit more about what Nasra is thinking and how we could certainly do that, because SOM is not a union. I don't know if SOM would see that as their remit and would want us to be able to go in as that task force and be able to address those issues. But we can certainly support colleagues and members if they're having issues in whatever way we can.
Sorry, unmute, right, there we go. One of the other thoughts that I had was, because we have another one of the talks in this series, but this is more relevant to the NHS, but the Speak Up Guardians.
Yeah.
So within the NHS, it's a movement towards people airing their concerns in general about organisational life. And so it strikes me that that might be another sort of, established forum for bringing issues, and that is supposed to be confidential, and then there's advocacy to actually explore the issues and develop them. So that's one other thought that I have about that. And then I suppose I'm also thinking that usually HR, if you're in an organisation that has HR, it might be an HR particular thing that, that they have a role in for instance, training, awareness, etc., and advocacy. What do you think?
I agree, and I think this is where the value of the employee resource groups or affinity groups come to play, because they are within the organizations and they are made up of employees, and they have that special accountability channel with HR as well as senior leadership within organizations. And that's where some of these issues can be raised and escalated, and most cases they are anonymized and they're presented as themes. But then there are the individual cases that get dealt with on a case-by-case basis in a confidential manner as well. So I think everyone has a role to play to some extent. We've got the professional bodies that come through, the FOM, the likes of SOM, that can raise it and work with the likes of BMA, which are the unions, and the other professional bodies to highlight and make sure, there is some form of monitoring or accountability. But I think on a small scales within the organizations, that's the value of having those affinity groups, HR, and those relationships with strategic leadership, who should take ownership as well.
Thank you very much, Sade. One of my other questions, actually, whilst you were speaking, I was thinking, goodness, as an external provider, I mean, particularly, I was struck by the one of the points that Sheetal made was that people who maybe are of minority group might actually be more inclined to get disciplinaries because maybe, for whatever factor within the system, might be more prone to having disciplinaries rather than support. And that actually really struck me as, my role as an OH provider, occupational physician, and I suppose being alert to the fact that that might be, something going on in the background, even in a very unconscious way, and thinking, well, actually as an OH provider, I wonder how I can influence into an organisation, even if I've got a suspicion only, rather than objective evidence, that that might be part of what's going on. Any
Absolutely.
thoughts?
Well, two of the cases that I presented were actually ethnic minorities, and they were going down the disciplinary route. But for me, it was a call to action and reminder to those that are involved, especially management and HR, to know their duty of care and to highlight the specifics of those cases. So for the likes of Peter, who was an African, who was a Muslim, and who on exploring the details of his case, there was a degree of harassment and bullying going on, and it needed to be brought to light. And he had been seen by OH twice, And all they had said was, you know, the typical, do a stress risk assessment. There are work-related issues, they need to be addressed. But I think sometimes as OH professionals, we need to be more specific in calling out some of those issues where we know that there are laws and there are statutory requirements that to support them that need to be called out, and the employer needs to do something about them. And I think the awareness education bit is very important. And in his case in particular, I ended up going into training the managers around cultural awareness, which for the life of me, I shouldn't be doing in the 21st century, but there you go. If it comes up, we use that opportunity to make that difference. And in this case, it did help, and hopefully it will help other similar cases in that organization as well.
That's really interesting, Sade. What I'm wondering though was that in-house?
No, I did this as a trainee, and as you all know, my training was done in a commercial sector through the company that Sheetal's currently working for. So we were all external. But in my role because a lot of us, so in that role, even as a trainee, you take on some clients, they give you contracts to oversee. And I used that opportunity doing our yearly, quarterly and yearly meetings to liaise with the HR and senior managers and account managers for those organizations. And if we see particular trends, you highlight them. And if you see a particular issue, you get involved. And I know it's far and beyond me as a trainee, but I felt it was something that needs to be done. And I don't see why other OH professionals can't do the same.
Fantastic, that is brilliant to hear. And that I'm connecting that up in my mind as well with some of the resources that Sheetal put up. I think, you know, that might be really useful bits of information to put into reports, is, for instance, the business in the community toolkit, for example. So that's I hope that we're going to get the slides, are we?
Yep.
Yeah, absolutely. No
Great.
problem.
Now, I think those were our questions, but there were some very nice comments as well. So there was a Paul Williams, wonderful, thought-provoking and inspiring event. Thank you to great speakers and for organising. So that's very good. And some more thanks for the event. And also, thank you very much for inviting me. I had brilliant learning here. I hope to join again soon. So well done. I think that really has been a very interesting and thought-provoking. Oh, we've got another comment actually I've just seen. Sorry, I didn't spot that just before. Nasrat has written back saying, I think we cannot rely much on HR, as in conflicts they're usually seen as part of the employer. The idea is to make the organisation as an external body dealing solely with EDI issues to represent employees. But such an organisation should be empowered to do so, but unless we start it, we won't see such an organisation in reality. We can start it only for doctors and later on. Nasra, I think you need to join the EDI Taskforce. Sorry.
I was just thinking that.
Or maybe, I don't know whether one of the speakers might be interested in taking forward that conversation with Nasra. I think whether there are any other options. Haha, would love to. Okay, great, good. Are there any final comments before we close today?
Yes, just a reminder that we do have the Diversity and Inclusion Facebook group as well. That's been set up by some. So if anybody doesn't want to join the actual task force, but they still would like to be able to contribute, then that's a very useful resource.
Thank you very much, Janet. That's a good point. That makes it easier for people to join in different ways. So good. Well, what an interesting conversation we've had today. Thank you very much to all of our speakers. So Dr. Chavda, Dr. Adenekan and Janet O'Neill, thank you all very much for that. And thanks also Nick in the background for supporting the webinar. Lovely to see you all. Have a good afternoon, everyone.
Thank you.
Okay.
Thank you. Bye-bye.